Good morning, good afternoon, everyone. Thanks for coming to the November version of the RCSI Institute of Global Surgery Grand Rounds. My name is Mark. I'm the chair of global surgery here. A couple of housekeeping issues before we get into the presentation. As Deirdre has put into the chat, we have a spectacular presentation from Dr. Kachimba, whom I'll introduce in just a second. He will speak for the first half of this hour, and then the second half of this hour will be devoted to questions from you. So if you have questions as Dr. Kachimba is speaking, please feel free to pop them into the chat box, into the Q&A button at the bottom of your screen. Rather than the chat box, sometimes it's hard for us to keep track of what's happening in the chat. So pop them in the Q&A box and we will address them to Dr. Kachimba. So with that housekeeping aside, let me introduce our speaker for today. John Kachimba is a consultant urologist and senior medical superintendent at the Livingstone Central Hospital in Zambia. He received his BSc in human biology and his MB-CHB and M.Med from the University of Zambia School of Medicine. He holds an FCS in urology from the College of Surgeons of East, Central, and Southern Africa. For the last decade, Dr. Kachimba has been part of 2 EU-funded surgical system strengthening research projects in collaboration with colleagues here at RCSI, as well as colleagues from the Netherlands, Malawi, and Tanzania. In addition to his hospital administration and clinical care duties, Dr. Kachimba is also editor-in-chief of the Medical Journal of Zambia. Dr. Kachimba, thank you for speaking to us today. Over to you.
Thank you very much, Mark, and good afternoon, good evening, good morning, ladies and gentlemen. It's a pleasure to be invited to speak, and it's a pleasure to interact with colleagues in global surgery. My talk will look at essentially the effect of bringing surgical care to the fore. And my presentation outline is as listed there. It's a fairly short presentation that's designed really to encourage discussion on how to make surgery more effective in lower middle income countries. Next slide. As Mark introduced me, I'm attached to quite a number of organizations, but I must stress that the following presentation expresses my personal views, and in no way are these the views of either the Zambian Ministry of Health, the Surgical Society of Zambia, the Coast or Surgery Africa projects, or the Zambian Medical Association. Next. I think for Zambia, the attainment of universal health coverage, we have realized can be facilitated by improving the provision of quality surgical, obstetric, and anesthesia care. It's been a neglected problem for a very, very long time, not only in Zambia, but I think in the sub-Saharan region. And the World Health Assembly's resolution brought a very pertinent issue to the fore and gave us, the surgical fraternity in this part of the world, really the impetus to urge our governments to participate in making surgical care more effective and meaningful for our population. The next slide. Needless to say, poor surgical care invariably will lead to premature deaths, especially for the economically productive members of our society. And for those who seek even more complex surgeries, which are usually hosted by hospitals in urban areas, they really endure catastrophic expenditures to get that surgery. For those that can't and are left with a disability, the ability to make a meaningful economic contribution to their families or their societies is heavily hindered. And ultimately, the country suffers as a consequence. Hence, the next slide, the resolution brought out key points that we in Zambia, the next slide, we in Zambia utilized in formulating the National Surgical, Obstetric, and Anesthesia Plan for Zambia. We looked at issues of infrastructure, human resource for surgical care, ensuring the availability of essential anesthetic drugs, trying to mobilize financing, and hopefully ring fencing that financing purely for surgery in an environment where we are competing with infectious diseases, malaria, TB, HIV, that really affect millions and millions of our population. It's very difficult to convince the government to put aside funds purely for surgery. Then we looked at improving referral systems, because many of our population are spaced out in very vast areas of the country and are in very hard to reach places. For those, it will be easier, and it's always easier to move them in. So you'll ask, what is Zambia? The next slide. Zambia is a Southern Africa country. It's landlocked. We have about 8 neighbors. It became independent 57 years ago. And when the Union Jack was brought down and the fish eagle took to the sky, we inherited a good economy, a small manageable population. The revenues from our copper mines were excellent. They allowed us to give the population a good standard of living. Rural poverty was at a minimum. Our health services at the time, our medical doctors were largely expatriate and brought in by the mines, and these were centered really around the mining areas of the copper belt and the commercial capital, which is the capital city, Lusaka. Both these main provinces along the line of rail, and to this day, most of the economic development, economic activity is still centered around these 2 provinces. We always say that 80% of our resources are actually expended on 20% of the population living in these 2 provinces. So 80% of the population in the more rural parts, as was in the pre-independence state, their healthcare is provided by non-physician clinicians. Initially, prior to independence, they were called medical assistants. They were informally trained, usually in mission hospitals or on the mines, to be able to make a diagnosis of common conditions and start oral treatments and then refer. Soon after, in the early 60s, around 1962, a college called the Chainama College of Health Sciences was established, and this training of non-physician clinicians was formalized, and they began to receive a diploma in clinical medicine. Their name changed to clinical officers. As the years passed on, the needs were passed on to them due to shortages of staff. So clinical officers who originally did general medical duties were now being trained to do anesthetic work. They were being trained to do psychiatric work, and we have continued to task shift to this day. Presently, the clinical officer training has been upgraded. They're now called medical licentiates. Their role has been elevated. Their skills in surgery and obstetrics have been enhanced, and they've been encouraged to take up greater leadership roles. The medical licentiate is essentially designed, or an innovation, to allow us to have a capable clinician at the district who's able to make a diagnosis and effect a surgical treatment on patients in far-flung districts. The National Health Policy has always recognized that the backbone of the health system in Zambia is the clinical officer. And as we moved on, fast forward to 1991, things took a downturn. Our economy was in the doldrums. Our health facilities, infrastructure, human resource had deteriorated significantly. The ravages of the HIV/AIDS pandemic were becoming more and more evident. And we realized that we needed to continue to provide care to our populations as close to the family as possible. And that was the mantra for the National Health Plan that kicked in from 2012 to 2016. 2017 to 2021, we were now talking about leaving no one behind, and looking at the resolution 68.15, one key indicator that we needed to address as Zambia was the issue of maternal mortality. At its worst in 2016, we were having a rate of approximately 398 maternal deaths for every 100,000 live births. And these were really resulting from hemorrhage, postpartum hemorrhage due to an atonic uterus, hemorrhage due to uterine rupture. And these we realized needed to be addressed expeditiously, preferably in the districts. They would not survive a trip to a referral center. They would not survive a trip to any of our central hospitals. So it really reinforced the need for us to strengthen surgery, obstetrics, and anesthesia at the district hospitals. Next slide. So the 7th National Development Plan had within it the National Health Strategic Plan to run from 2017 to 2021. And in it was the National Surgical Obstetric and Anesthesia Plan 2017 to 2021. And the situation analysis for this was based on work that had mapped out disparities in access to safe, timely, and essential surgery for our people. And it looked at surgical capacities in terms of supplies, human resource, and infrastructure, and each of our district facilities, and to see how well the populations were served. Were they able to receive effective surgical care within 2 hours at a hospital that was equipped and well-staffed? Unfortunately, the paper concluded that a large number of our population, they estimated that probably 74%, did not have access to that kind of care. And hence it was imperative that we move to improve it. One of the conclusions they reached as well was that if we were to improve our district hospitals, resource them adequately, bring them up to a level where they're able to provide surgical care in terms of infrastructure, human resource, equipment, and supplies, then we'll be able to see a positive increase in the number of people who are able to access care. Next slide. Next slide. Next slide. So to help us achieve the goals of the surgical plan, the ministry came up. Could you go back one slide? Yeah. To help us achieve those goals, the ministry came up with a number of legacy goals in 2016 that we hope to achieve while carrying out the current plan. And these related and needed a very strong surgical system within our district. Key among that was the issue of maternal mortality. We needed to reduce the 398 rate to less than 100 per 100,000 live births. And that included increasing the number of healthcare workers. The hope was that among those that we would recruit were those who would make up our surgical teams. We needed to increase financing to our district hospitals. Hopefully that this funding would be channeled to improving and ensuring that the surgical systems were taking place. It included the construction of a number of hospitals, specialized hospitals in our 2 urban provinces, and 2 others in the rural provinces to serve as referral centers. We needed to upgrade all our district hospitals and also construct a number of health centers that will be able to identify patients in the community and allow for their referral to these district hospitals. There was the key goal to train specialized staff. We aimed to train 500 specialists in all the fields of medicine through the creation of the Zambian College of Medicine and Surgery. And for the surgical fraternity, we're really looking at training a lot of anesthetists because they have been the shortfall and the weak link in all our hospitals. Next slide. Next slide. So, come 2017, huge infrastructure projects took place. And as we speak now, the National Heart Hospital has been complete. 106 district hospitals were upgraded, infrastructure, equipment to be able to deliver surgery. 24 general hospitals also upgraded to enable them to provide surgery. And then we realigned our tertiary hospitals so that we could respond to the specialist needs of patients. And among the realignment was the creation of 3 dedicated women and newborn hospitals that would improve the management of mothers with acute, severe complications in pregnancy, as well as improve our ability to resuscitate and life support the newborn. These 3, unfortunately, are all along the line of rail, but we believe are just the beginning. And some of these projects were quite dramatic for the communities in which they were put up. Next slide. This illustration, next slide. This illustration is of a hospital in the center of the Eastern Province that had no referral hospital. It is to serve as a regional referral hospital in the Eastern Province. It was built and completed early this year, equipped and ready to provide service. Next slide. In the midst of the recession, when government wasn't employing anymore, we were still able to convince the state to employ and increase the number of healthcare workers. Our particular interest, as I had mentioned earlier, was the nurses to work in theater, the clinical officers and medical licentiates who would serve as surgical providers in the more rural parts, and the general duties medical doctors who will be able to train to provide emergency and essential care. Next slide. Along with the training of specialists was the purchase and procurement of equipment. Ambulances were brought in to facilitate the referral system. Anesthetic machines, operating tables, and ultrasound devices were all brought in, largely in those areas that were suffering the greatest burden of maternal wastage. And these were done along with cooperating partners. CEDA, for one, is very keen to see a reduction in maternal mortality and has been working in a number of our more rural provinces to provide infrastructure support, provide training for first responders, and to provide equipment. Next slide. As a result, most of the newly constructed facilities actually had resources that were state-of-the-art, ready for service to communities where they are located. Next slide. And for patients that needed referral, next slide. Every district hospital was provided with a basic life support ambulance to enable safe transfer of patients to a higher level of care. As for anesthetic drugs, the next slide. 2 drugs were added to the government formulary. And through an act of parliament, the Zambia Medicines and Medical Supplies Authority was created. It was given the mandate to ensure that the supply chain, especially for anesthetic drugs, was reinforced and that each and every facility would have access to those. Next slide. Another factor that we looked at improving was the issue of surgical information systems. At present, the ministry is operating what is called the Smart Care Patient Electronic Health Record System. It's an integrated health record system that provides continuity of care and clinical management, and originally was limited to the HIV and TB programs. These programs were deemed to be very sensitive programs that dealt with very personal information. We needed to increase confidentiality while reducing the burden of paperwork and improving the quality of data that we were gathering. And for the clinicians, we hoped it would make for better decisions at the clinical end. This is now undergoing an upgrade and re-engineering to encompass all facets of the health system. For surgery, we hope it will not only be collecting the numbers of operations done as it is doing presently, but be able to be used in our wards, our outpatient clinics, and during our outreach activities, so that we are able to estimate the burden that still awaits surgical management. Next slide. As for financing, the financing of surgical and anesthesia care in Zambia, like in many sub-Saharan countries, is rather poor. And in a country, like I said, with a huge infectious disease burden, it's very hard to compete. And you need a district that is keen to improve its surgical performance, that will allow for the ring fencing of funding to purchase the consumables required to carry out surgery. As we speak right now, the 10-year healthcare financing strategy has been released. There's not a single mention of the word surgery. So the fight continues to ensure that we can get as much funding as we need to allow us to provide safe and effective surgery. So with that brief of what we had set out to do and actually did, the question still begs an answer is, with all the inputs that we had put into the surgical systems, what target had we set ourselves? Now, there are a number of targets we had set ourselves, but I'll pick on one, which is on the next slide. And this is a target on surgical volumes. According to the mapping study that had been done in 2016, that the estimated need was for us to be doing 6,145 procedures per 100,000 population. We were apparently doing 1,617 procedures with a huge deficit. So our target was to meet at least 80%. That was about 4,916 procedures per 100,000 population. Was there any difference after that was instituted? Next slide. Next slide. I apologize for the crowded slide, but this comes from a huge database at the ministry. The next slide, yeah. And this looks at absolute numbers, the number of cases that are being done in our various provinces. And I picked the years 2018 to 2020 because they are the only complete sets of data. They include not only public or government hospitals, they include private for-profit hospitals, they include our mission hospitals, and I think they reflect what we are doing. The private for-profit hospitals are doing a fairly low number of cases when compared to government facilities. But when we look at the numbers, what strikes us most, even when you can look at the fact that COVID came into Zambia on the 18th of March, 2020, the numbers were still low. They were low before COVID, they are low now. And the reasons that we needed to find out is why our operating teams were not meeting the numbers of cases as we had targeted. Lusaka and the Copperbelt, like I said, are urban provinces. Most of our specialists are in the university hospitals, and both university hospitals are within these two provinces. Most of the human resource, doctors, nurses, support staff are within these two provinces, and yet the outputs were still not good enough, extremely low. The next four provinces are rural provinces with relatively good infrastructure. Their numbers are slightly better, largely because they have a lot of mission hospitals that carry the heaviest burden. The Eastern Province, the Southern Province, 3/4 of the major general hospitals are actually mission hospitals, and their outputs are significantly higher than, unfortunately, our public hospitals. So our operating theaters remained poorly productive throughout the whole country. even with the onset of COVID, which has shown the weaknesses we have with regards to anesthesia and critical care, the numbers have still remained low. Next slide. The final 4 provinces are the least developed, with the fewest resources, both infrastructure and human, and their numbers, as expected, are low. The question is, we're asking ourselves, why, with all that we had put in, or did we put in as much as we think we did? The next slide. When we look at surgical providers, the actual numbers of healthcare workers employed were high, but when you look at surgical providers, we had very, very few. Few surgeons employed during this period, a few medical licentiates, few theater nurses. Most of the theater nurses were through an in-service training program, and they went back to their stations, the stations of origin. Many of them left service because even after training, the ability to increase their pay due to limited Treasury authority resulted in job satisfaction and the need to move into the private sector. So our numbers of surgical providers, especially in our districts, remain very, very low. And as a consequence, our maternal outcomes, which are the easiest to see, are not as good as they should be, bearing in mind the huge outlay that was made by government. With regard to anesthesia providers, the next slide, these remain the lowest in terms of numbers and the most critical. Many district hospitals do not have anesthesia providers, and in spite of initiatives to increase their numbers, such as the introduction of the nurse anesthetist program, as well as the expansion of the intake for clinical officers in anesthesia, the numbers being recruited on these training programs remain very, very low. And going into 2022, I see no reason to think this will change. Both the clinical officers anesthesia and the nurse anesthetists have had their position on the employment establishment elevated, so they get higher salaries and better conditions. But even that has surprisingly not attracted a lot of officers to take up anesthesia. As I mentioned earlier, COVID-19 has really exposed the current weakness that we are seeing with regard to anesthesia. Most of the treatment centers are presently in the urban provinces of Lusaka and the Copperbelt. So most of our anesthesiologists were actually deployed to these treatment centers, leaving district hospitals and the more rural general hospitals without anesthesiology cover. And we've had to continue to depend on the clinical officers in anesthesia. And now we have the nurse anesthetists to do most of our work. But even then, their numbers are few, and their ability to really provide for large numbers of cases is limited. All this has been compounded by infrastructure challenges, which are on the next slide. The last 2 years have seen a critical shortage of electricity, hydroelectric power in the region. We have not been spared. Long periods of load shedding have affected not only hospitals, but even security installations. So we've had numerous complaints of power outages that have affected service delivery. The water supply to most of our hospitals, which is usually provided by a government water utility company, has been intermittent and low in quantity. Some have complained of limited surgical instruments and ability to sterilize. And of course, in spite of the enactment of the ZAMSA Act and the commissioning of the Act itself, we have still seen shortages of anesthetic drugs. This may have actually been caused by the new regulations that have been imposed on the importation of anesthetic drugs and narcotic analgesics. and it has reduced the number of private players to whom we go when the government's unable to provide these drugs. So on the market, we have very, very few options when it comes to buying these drugs. So how do we stimulate surgical productivity with all the problems that we're still seeing? And probably that's one of the reasons why I'm happy to talk here. Maybe we could share ideas on how do we stimulate surgical productivity in 2022 going forward. Next slide. We have seen that all hospitals, even our university hospitals, are not really operating at the levels and the rates that we would love them to do. So how do we get these hospitals operating again? How do we get the specialist hospitals to start giving back on the, giving returns on the huge investments that government has put in? How do we get the districts working? Obviously, we need more people performing surgery, especially in the districts. Unlike other countries that may actually train enough surgeons to fill out district postings, I think we'll continue to depend on general duties medical officers with short-term training to do surgical procedures. We'll continue to depend on non-physician clinicians to do surgery. We will continue, we can go back. We will continue to depend on our nurse anesthetists to provide anesthetic care. What is even more important, especially for our university hospitals, is that we need to manage productivity among our surgical providers. We need to manage performance. We need to set realistic targets and create an environment that will allow each and every one of them to meet their targets. As for specialists and professional societies, both local and regional, I think it's important that they assume a much greater role, both in training of more specialists, as well as in the supervision of these district level surgical and anesthetic providers. They need to be part and parcel of ensuring that the district teams continue, start and continue to work and work efficiently. We need to effectively distribute skilled personnel. As I'd said earlier, there is a bias towards the more urban parts of the country. Over 80% of our specialists are serving 20% of the population. I think this cannot continue. If we're going to extend the specialists' influence all the way down to the districts, it is important that we get them out of the urban areas into rural areas, supervising and overseeing the surgery that is being carried out in remote districts. The next slide. With regard to the information system, this has been the most difficult to date to resolve. Getting the smart care system to be used in the clinical area has taken us years. We set it as a target in 2017. To date, we are still not able to deploy it in our wards, in our clinics. We're still not able to use it remotely when we do our outreach services. We need to revisit this and make it a high priority within our next plan. For us to really assess the surgical burden, we need to know what's outside of our hospitals. When we go out for our outreaches, are these patients that we are diagnosing and referring to our centers, are they coming and having treatment? The next slide. Over the next 5 years, it's important that policy changes must be made that will allow for the decentralization of surgical care right down to the districts. Right now, the government is moving to decentralize the governance system right down to the districts. It's important that we do the same for surgical care. The units in the districts know the burden that they have to deal with. They know the amount of money that they need to address it. So we need to allow planning and budgeting for surgical services to be done by districts. For too long, it's been done at the center, and it has not responded to the needs of people in the district. So I think a change is in the offing that will allow our districts to set achievable yearly targets. The next slide. And finally, and more importantly, I think we need to expand and work on our engagements with development partners, be they cooperating partners, academic institutions, professional societies, international and regional surgical and anesthesia colleges, obstetric colleges. We need to start working together. Firstly, we need to generate the evidence that speaks to the value of improving surgical services. Politicians need to see the value of having good surgical systems, that they lead to strong economies and wealthy states. They are not consumption activities. They actually contribute to economies. We need to provide the proof that improving surgical care leads to economic, socio-economic improvements. We need to involve ourselves in training of graduate students in surgery, obstetrics and anesthesia. We need to involve ourselves in training the NPCs and general duties doctors. Using the fellowship method, it will allow us as regional partners, as international partners, to exchange human resource and network so that we allow the mutual development on both sides. We need to work to revamp specialist outreach programs, both on a national level, as well as with international partners. For many years, we did an outreach with IVU, a US Society of Urologists. For years, we have done an outreach with a cooperating partner to provide specialist plastic surgery to the more remote communities of Zambia. To this day, it's the single most successful specialist outreach in the country. It provides a service to rural populations. And when Goran Jovic flies, he flies with fellowship students and teachers. And he provides them an opportunity to operate with him on cases they will never see in urban centers, because these are poor communities that cannot afford to travel into towns and live with the disabilities that he has worked for decades to correct. And this is both local and international. It would be good to involve international partners in such initiatives. We need to open links with universities and university hospitals, both in the north and south. And these links have worked wonders. The urology master's degree program from the University of Zambia is the brainchild of a north-south partnership between the University of Zambia School of Medicine and the Association of Anesthetists of Great Britain and Ireland. It has trained doctors to become specialist anesthesiologists. It has trained nurses to become competent nurse anesthetists. We need to build on those kinds of relations. Right now, the King's College Hospital is working with Ndola Teaching Hospital to introduce laparoscopy and endoscopy. We need to build on such relationships so that our specialists can really be challenged to do the kind of work that they were trained to do. It may reinvigorate them, and we will see increases in the number of cases they do. They'll get greater enjoyment in what they do, and certainly they'll become stronger advocates for improving surgical care. So my final words really, I might take next slide on what the larger group said. I think mine is just a call to all surgical providers. And in surgical providers, it includes the obstetric care providers, the anesthesia care provider, the theater nurses, the biomedical engineers who maintain our equipment. It's a call to action. We need, through our national, regional, international professional association, to involve ourselves in advocacy. The fight for funding, the fight to protect our surgical services needs to be fought by those of us who are practicing surgery and its allied professions. It's important that we tell our politicians why we need that funding and how it helps the country as a whole. We need to involve ourselves in training of the whole team. We need to collaborate in research, and we need to participate in health service management. It's only by doing that that I think countries like ours will begin to see an improvement. Most of the things that are easy to do is the purchase of equipment, the building, erecting of a structure here and there. But to get the healthcare worker stimulated to contribute in a big way, I think there are so many factors that kick in, and all of us have a role to play in making it happen. So with those final words, I want to thank you all for the opportunity to speak. I want to acknowledge colleagues from the Surge Africa project, a dear friend, Dr. Makasa, colleagues that I work with in Southern Province. And thank you so much for listening. Thanks.
John, thank you. That was a really impressive talk. It was a broad overview of what's been happening, but also I was really impressed with sort of the honesty that you dug into each of these topics with. So thank you for doing that. We've got about 15 minutes maybe for questions. Just a reminder to the audience that the Q&A box, there's a button down at the bottom of your screen, is open if you have questions for Dr. Kachimba. But let me start with a question that's in the Q&A box right now from Christoph McGowan. Christoph writes, your work on developing clinical officers in surgery is very impressive. How would you encourage surgical leaders in other sub-Saharan African countries to take this forward in their countries?
May I take that?
Absolutely, please.
Okay. I think the first thing is really to allay fears. The biggest obstacle for surgeons, medical doctors, to accepting non-physician clinicians is an unrealistic fear of losing something. I've never understood it personally. I've never understood it. So we tend to protect our turf. So first thing, and we've discussed this at the College of Surgeons of East Central and Southern Africa. A lot of my peers are apprehensive, and they'll use issues of quality of surgery carried out by these officers as a reason why they don't want it. My response to that is simple. Involve yourself in training them. If you train them, you take responsibility for the product that is produced. And the work we did on Coast Africa, we actually showed that if you train them well, the output is comparable to work that is done by doctors. So the issue of quality falls back on us. We can't throw it on these NPCs. It's back to us because we train them. We share the task. We decide what they can handle and what they can't. So the biggest thing is really to reach out to our surgeons, reach out to our doctors, and reassure them that these are colleagues that are helping us dismantle a huge burden of disease. There will never be enough surgeons in sub-Saharan Africa to carry the burden that we currently have. I think it's estimated less than 6% of the operations are being done in sub-Saharan Africa. We are way behind. We can't afford to deny a fellow surgical provider the opportunity to play their role. I think that is wrong, and I've stood against it for years. I'll go to my grave defending that position.
Well, hopefully there'll be some change before either of us are in our graves. Let me ask you, I want to follow up on that before I get to another question that's in the Q&A box. Do you find a similar fear in your experience, a similar fear expressed by patients, or is that fear really only from providers?
It's only from providers. It's only from providers. It's only from providers.
Yeah. I suspect that's the case. I have another question here from Eric O'Flynn here at RCSI. Many thanks for an excellent talk, Dr. Kachimba. Do you have any examples of rural provinces or districts that you feel have actually achieved a productive and efficient balance of specialist and non-specialist surgical providers? And if so, what did they do to achieve that balance?
We have one province that has achieved a fairly good balance, but that one is not the norm. It has a predominance of mission hospitals, and mission hospitals function in a very different way to public hospitals. They are a lot more efficient with a lot less in terms of resources. And the mission hospital, the ethos, in public government hospitals. So we have definitely in the Eastern Province, we have hospitals that have been able to retain a very strong cohort of non-physician anesthesia providers and surgical providers. And they are all supervised by a doctor, usually a surgeon or obstetrician. And the key is they have built this team spirit where everybody feels they're making a very valuable contribution. We don't see that in government hospitals. I think there's too much infighting and turf protection. But definitely in the Eastern Province, and those are the key hospitals are all faith-based. So the way they do things is a lot better than what we are seeing in public facilities.
Do you know in that region, in these hospitals, are there other things besides the team spirit in terms of salary, in terms of other opportunities that are also retaining people?
Sorry, Mark.
Can you hear me, John?
Hello? Hello?
John, can you hear me?
Sorry, can you hear me?
Yeah, you're back.
Okay. You were saying?
I was saying within those particular hospitals, besides the team spirit that you are mentioning, are there other concrete things such as potentially salary or other opportunities that you think might be helping retain people?
Oh, yes, absolutely. Absolutely. What the hospitals provide is very good accommodation, very good schools for their children. And what most of these hospitals have built is a little community. So everything is provided. They never have to worry about the everyday things. Right? They have food on the table. They can get to work safely. The kids go to school. Accommodation.
I think we may have lost John's feed. We'll give him a couple of minutes, and if not, we'll go on from here. Looks like we've lost John altogether. If he comes back, we'll put there are two other questions in the Q&A box that we can put to him. While we're waiting, Deirdre has just popped in the chat box over on the right. The next first Wednesday of the month is December 1st. That is World AIDS Day. So we will not be having our global surgery grand rounds on that day to allow the opportunity for you all to go to one of thousands of World AIDS Day conferences and other things happening. We will also be taking January off simply for the holidays. So the next global surgery grand rounds that we will have is the 2nd of February, February 2nd, the first Wednesday of February. We'll have two presenters from RCSI itself, Professor Walter Epic and Dr. Marie Morris. Will be talking about the development of simulation techniques, simulation platforms within global surgery. The other announcement is that the month following, so now we're talking 4.5 months from now, but we're just putting this bug in your ear. RCSI will be hosting the first annual Dublin meeting in patient-centered global surgery. It will be taking place on the 15th and 16th of March. It will very likely be primarily virtual. You will be seeing more about this on Twitter. You'll be seeing more about this in your emails. And within the next week, week and a half, we will release a call for abstracts. So if you are a student, a trainee, a surgeon, an anesthesiologist, anybody interested in the global surgery space, keep an eye out for that, because we'll be accepting abstracts for presentation at the meeting in global surgery on the 15th and 16th of March. I think, given that we have lost John and he's not back, we'll just end a couple minutes early. So thank you all for being here. If you have any questions that John hasn't answered and you'd like to pose them to him, please send us an email at globalsurgery@rcsi.com. Also, John has agreed to make his slides available. So if you want to see his slides as well, drop us an email at globalsurgery@rcsi.com. Again, thanks for being here, and we will see you in 3 months on the 2nd of February.